I'm Amy Goldman. I'm a physical therapist by training. I went to the University of Nebraska Medical Center and graduated there in 2000 with my master's degree in PT, and then in 2002 I got my doctorate, my transitional doctorate in physical therapy from the same institution. I've been at Madonna since February of 2001, so 16 years, I'm proud to say, and I started off as a clinician to gain experience. I actually floated. I was kind of considered now what we call agency staff, a float therapist to gain experience, but I always knew neurological patients were where I wanted to be and who I wanted to be treating. I have experience though with a variety of conditions, but stroke then, a few years into that time of floating, I became a primary PT on the stroke team on acute rehab at the Madonna Lincoln campus. Worked there for 4 or 5 years, gaining more experience, and in that time, gait training or locomotor training was really my specialty, what I was very, very interested in. And at that point or so, or even before then, Dr. Burnfield and her team had brought in several of us to really serve as physical therapist, clinical experts. I will say I'm not good with statistics or any of that stuff, but I can bring in that clinical, day-to-day operational piece of what really happens in the clinic, how we deliver care, and offer that level of expertise to the research studies that we've done. And then serve in the PT role if I need to be in the training therapist role in some of the studies as well. I became stroke program manager in December of 2005, so I've been doing that just over 11 years. What that entails is initially we still had about 30 to 40% patient care time because I never wanted to give that up. And again, within those years, I would do things like partial body weight support treadmill training. I was more of the expert in that. I would train staff on that device. I would do training a few years after that, we ended up with the Locomat in Lincoln and got trained as a super user on the Locomat through Hakoma. So becoming a super user in Lincoln, there were 6 of us at the time. We then were able to train new staff that would come on to either brain injury, stroke, or spinal cord injury, acute rehab teams. So the way Madonna structured it, we essentially had 2 to 3 trained locomotor therapists on each of those 3 teams. So no matter what team the patient would end up on that would benefit from that intervention, if you weren't a trained therapist, they would get those patients on our schedule so that we could train them 2 to 3 times a week on these devices. Then came along the eye care, and I got trained in that, and it's an awesome device. We really like it in the fact that essentially all the gait kinematics are the same, and it's a lot more affordable. We can use it for cardiovascular training. We can use it for gait retraining, for walking recovery. It's getting our patients the ability to get up sooner in their acute recovery phase of their neurologic injury. The effect that it still has the body weight support mechanism, as you all know that are familiar, that allows our patients that are unable to support their own body weight to get into a device like this and begin aerobic training in gait-like movement patterns that we know through mass practice stimulates neuroplastic changes in the brain for motor recovery. And that's really what our premise is in our physical therapy area here at Madonna. Our therapists are very keen into the research, which I think having the Research Institute makes us able to do that even more. We're very proud to have this part of Madonna, and they keep us in the loop of the latest in this type of technologies that we can then implement directly into our clinical practice here in our therapy areas. With that also, the research in the neurosciences is why we do what we do every day. We try to emulate exactly what we're learning through the research is best for these neurologic patients. We know they need a task-specific training, they need a lot of repetitions, so we choose devices like the eye care that we know can get us that. Does that make sense? And that, in addition to their traditional therapies, really augments their overall therapy regimen that they're allowed to have here at Madonna, unlike other hospitals that don't have this type of specialty equipment. And we know one of the downsides of something like the Locomat is the cost and the space it requires to put it in a gym. And a lot of these skilled nursing facilities, if you've ever worked or been in those, the gym is half the size of this room. They have one therapy mat. They might have a set of parallel bars. There's not enough room, unfortunately, for this specialty equipment. So places like Madonna and some other smaller rehab units, assisted livings, I know we're looking at it in people's homes that have room for the eye care. It's very much an affordable, effective device to retrain walking-like movement patterns while also helping with neuromotor recovery. And we're very, very proud of it. Anything I hope I'm answering your questions and explaining how we utilize it here at Madonna in a clinical sense as well as the research sense. But feel free to fire away. I want to make sure that I'm answering, and I assume you're going to edit this. So I'm kind of just talking. Or do you need me to be looking at the camera?
Nope.
Okay.
You can address the crowd.
Yeah.
Have you done any testing here in Madonna Hospital for the wounded warriors, soldiers that lost their legs and
We've done, I know, with brain injury for the wounded warriors. Dr. Burnfield, I was not a part of that, but I know years ago we have been involved in some research or therapies for wounded vets that have come back.
A 1 to 2 year period, we had 3 to 400
Yes.
individuals, wounded warriors who referred. Within the United States, and I may be wrong on this, I think the TRICARE system, help me remember, Amy.
Well, if you keep talking, I might remember too, but.
So vets who were coming back initially were fed in through the healthcare system, the VAs.
Through the VAs,
TRICARE,
yes.
The TRICARE, so there were facilities that cared for them, but then there was that overflow. And so when the overflow happened, we saw, I think within a year, somewhere between 300 and 400.
It was
that
several
a lot of it
hundred.
was the psychological aspects of it. So with this.
Yes.
It's been a lot of the post-traumatic stress disorder.
We saw some with concussive type disorders from concussion, from blast injuries, some wounds, but more the brain, the concussion and the depression and the emotional adjustment related to PTSD. From what I recall from speaking to my outpatient colleagues that treated those patients.
And so for us, they would be seen typically more within our brain injury
Yes.
service, which is a separate service from, has traditionally been a separate service from our stroke service.
Could you talk about, since considering the time that you did a series of therapy prior to eye care, and then eye care became a part of the therapy, part of the treatment plan, could you talk about maybe what you've seen in the patient population, what the recovery's been like, whether there's been improvements, or what you've seen in the changes since the introduction of the eye care, and how the outcomes have really changed?
I think both from a cardiovascular standpoint, endurance, physical fitness, just overall lessening that deconditioning aspect that we see with our chronically ill neurologic patient, even non-neurologic patients that are here with a debilitating condition. We've seen improvements in that quicker. The sooner we can get them in a device like the eye care and get them upright and moving. Also, just the ability to initiate movement in their lower extremities, because we're doing, again, gait-like movement patterns. We're also strengthening in here. And so if I had to say, I don't have exact data, but I can tell you from the therapist's feedback, they definitely feel their patients are recovering at a somewhat quicker rate when they have access to this type of technology. Because again, it augments what they're able to do from a traditional sense in the clinical setting, in the therapy gym, or out in the community, or the other things they're doing in those therapeutic areas around the gym.
So based on the amount of time that you have to treat each patient, how does this intervention work? Does it take up a lot of time in the intervention?
Oh, great question. I would say because it has an easier setup than definitely the Locomat. For instance, the Locomat setup takes almost 20 to 30 minutes to get the patient in. Once you're good at it after the first couple sessions, we could be getting in there in about 15 minutes. Versus the eye care, we're getting them in and going within a couple minutes. So in a 30-minute session, we're gonna get a lot more steps. And it's easier on the clinician to integrate this into their session. Plus the location is right in the gym where they're already bringing their patient. I would say they're utilizing this 2 to 3 times a week on average at a minimum, if it's part of their therapy intervention. Versus a Locomat, because of the setup time, the fact that we share that with a lot of different therapies across the hospital, we're all kind of vying for time on these devices. It actually has to be scheduled out for an hour because of the setup time and training time. A 30-minute session, of course, would get us nowhere. We set up for an hour, so you only have like, what is that, 8 or 9 slots a day for inpatient and outpatient. And now here at Omaha, that includes pediatrics because we just switched the legs for the Locomat. So eye care has the advantage of quicker setup time. They're in and out. They can do it in a 30-minute session, which means because of that, and they know they're having the same type of benefits as the Locomat, clinicians may go towards this quicker and then do it more times per week than the Locomat. Great question.
So like from an injury standpoint or a disease state, what steers you as a therapist to the eye care versus the Locomat? Or, I mean,
Yeah, there
do you have
is.
preference just as a therapist in general, or I mean, are you guys specifically looking at this type of injury, this type of condition? We're gonna go to this part of the therapy.
We've actually looked at kind of a locomotor progression here that we're slowly kind of working on, taking into account not only diagnosis, but type of injury and severity of their deficits. So when you think of the Locomat, the disadvantage of it is it locks the patient in. You have the legs that attach to the hips, and there's very little trunk movement, dissociation of the trunk from the hips, from the legs. And the robot's doing a lot of the work, although we can definitely back off on that, which we do. It takes the strain off the clinician. So when you compare that to manually delivered bodyweight support treadmill training, we like it now for our more severely affected patients because on the manual trainer, we would be all over the place, trying to control the trunk, the hips, the legs, versus on the Locomat, if we need that trunk control assisted with, we know we got it. And the machine's doing it. So then we can work on other things. So then when it comes to where does the eye care fit in, feedback that I get from therapists is this one is a little bit more difficult if they're pretty weak in the trunk and their legs, although they like this mechanism of being able to sit here and control that and being right by the patient. But because we have the option of essentially varying levels of assisting type locomotor devices, we progressively move them through. The disadvantage of keeping somebody in the Locomat the whole time they're here is they never get out into a more challenging setting, like the eye care. So I encourage my therapists to not stick to that forever. Use that more for your low-level clients that are very low level. We're talking, they honestly don't even need to have head control to be in the Locomat. If you don't know, if you're not familiar with a lot of the criteria, they can be fully supported in the trunk. There's 2 straps. So, and we've actually worked on tactile cues to keep their head up. Versus you can imagine putting that kind of low-level patient here. That would be a lot of work on the therapist. Not that it couldn't be done, but since we have an option for a patient that low level, we'll start there and transition quickly to the eye care.
Actually, that would be great. So what would be the minimum viable patient?
Dr. Burnfield and I have talked about this before. You could get an easily moderately affected patient easily in here. Incomplete spinal cord. We've had
And we've had patients with brainstem.
That's right, brainstem stroke.
I think what Amy's really hitting on is an important piece is that in a larger facility like a Madonna Rehab Hospital, we have all the different, in reality, we have
The
all
progression.
the different, progression types of technology.
Yeah.
And so we have the luxury of saying, well, okay, this person's had a brainstem stroke or they have this level of spinal cord injury. We'll start them in the Locomat because we have that as an option. Not all facilities
Will have
as
that.
an option. There are home users who have a brainstem stroke
Mm-hmm.
who are using the eye care. So I can think of at least one person with a brainstem stroke is somebody with a locked-in syndrome again, who doesn't have really very
Any
much,
movement really from the neck down.
yeah, so
Very
got a lot
weak.
of volitional control there, difficulty. We had that gentleman coming down from Michigan with a brainstem stroke to use the eye care to train on that. So you can have a more complex patient use the eye care.
Definitely.
But at Madonna, we have all the bells and whistles. But not every facility has that capacity.
And we have used it with more complex patients, and in that case, we may have a therapist on each side. being there just in case, and taking turns assisting the trunk, because we do want to take care of our clinicians. I have that from personal experience. I'm a big spokesperson for that now. You've got to be careful with delivering this type of therapy on a repetitive weekly or daily basis.
Cool, Kick, could you speak to that a little bit more then?
Sure. I ended up with some pretty chronic low back issues, which essentially about 2.5, 3 years ago became so bad I was essentially going to chiropractor, PT, trying it all, trying to stay away from surgery. And the nice thing about my job, I essentially could transition out of daily heavy lifting with patient care, because my job became so much bigger now that we were building in Omaha. I had plenty to do from an administrative standpoint, and we were now really more used on a consultative basis as program managers. More of our job is both internal and external, working on program development. But sitting for my job was killing me because of my bad back. So I kind of made my own makeshift standing workstation the last 1.5 years and started seeing a spine surgeon who, upon x-ray and MRI, could see that I had 2 to 3 herniated discs in my low back. I had bone spur issues in my upper thoracic and cervical spine, but the worst part of my spine was my lumbar area. And did about 4 steroid injections. Again, we were trying to put off surgery, but finally actually ended up in the ER, unfortunately, last November with what I thought was cauda equina. It was very scary. I was here at the Omaha campus and essentially had no feeling from my waist down. It was very numb, and I was having difficulty walking, and they were like, you need to get to the ER. So doing an MRI then showed that my condition had progressed to the point of needing surgery. And on January 31st of this year, I'm doing really well. I had a L3, L4 spinal fusion and laminectomy, and I am back to work full-time as of 2 weeks ago. I had to be off for 3 months. I'm doing therapy, I'm getting in the pool here. I'm a real big advocate though now for nurses and therapists. You've got to take care of your back.
Right.
Essentially,
Where did this originate from?
well, I was a volleyball player in college too, so all that, even though I can't do it right now, I shouldn't be doing it, all that arching and jumping on the gym floor between high school and 5 years of college, because I redshirted the first year, didn't help. But also it was the lifting and twisting, and I was on the stroke service, like Dr. Burnfield said. You, as therapists, you don't use lifts, even though we probably should be using them more. And I've been on a research study about that as well here, and continue to encourage our therapists to use sit-to-stand devices to assist themselves. Because we just get dependent patients up out of bed on our own. We don't get help. Nursing here has what we call a transfer recipe and a policy that if they are modest or greater, is it or max? I'm gonna blank now. It's either moderate or maximal, and it's a 35-pound or below lifting restriction. It's below that. They can't go above that. They have to use some kind of device, whether that be like a Vanderlift to completely lift the patient or a sit-to-stand device. And that has reduced our healthcare costs from lifting-related injuries by thousands and thousands of dollars. Our work-related work comp claims completely gone down. It's been at least 5 to 7 years ago that they implemented that. Only for nursing, though. Therapies haven't latched on to that policy yet. But they definitely have done training about preventing back problems and doing better with lifting. And they've encouraged the use of the sit-to-stand lifts if the therapists definitely feel like that patient is just too heavy for them to be maneuvering and assisting.
Could you speak to how the eye care works as far as how the therapist, their bodies are?
Yeah, like let's say the patient was right here. I mean, we still have to get down and use good body mechanics to help them either stand or do a lateral transfer from their wheelchair onto the seat. Mm-hmm. And we have the ability to go up and down with the seat so we can get that to be right at their level, which would require then less lifting, obviously, by the therapist. Once they're hooked up, it's essentially we would want to be close to them, so we're not reaching clear out to provide assistance. If you increase that moment arm, that's where you're putting all that force into your lower lumbar spine, and you've got to be very, very careful with that. So we teach them to get very close to the patient. You'll see the therapist right here, and or sitting in the seat while they're, or standing, to facilitate while they're up using the device.
And how would that vary versus other types of therapy?
Well, the one that I think caused me my two, I know, injuries for sure was on the manual system. I have maybe 2 reported back injuries here. Otherwise, it was hard to pinpoint what actually happened. It was just repetitive over time that I was sore during some weeks. But what got me was the sitting on the seat to deliver manual training and this constant partial body weight support treadmill training. Yeah, not the eye care.
Yeah.
The eye care is built in a way that we don't have to sit like that anymore and deliver therapy that way. It's an awkward posture, and you're doing that hundreds of times in a session, lifting a limb that potentially weighs, and quote me, Dr. Burnfield, what do we decide? Some of those bigger limbs can weigh up to 50,
If you had a
60
If
pounds.
you had a 300-pound patient, you could have a 48-pound.
48 pound, yeah, I mean, think about that.
Yeah.
Which is why we hooked up the EMG to the therapist's biceps to see how much is she having to lift and engage every time that patient takes a step. Again, up to hundreds of times in a 30-minute session, if you count all the trials we did.
From a reimbursement standpoint, and we kind of touched on this a little bit earlier, what type of codes, I mean, how are you seeing this being used as far as reimbursement, CPT codes, and specifically in comparison to like the local mat? I mean, is it the same type of?
Pretty similar codes you would bill. I mean, I typically have billed, of course, therapeutic procedure
Yep.
and or neuromuscular reeducation and gait training. I mean, it'd be those top 3 codes that you'll see used. For the Locomat, I feel like we would do more for a high-level patient that we want to do cardiovascular fitness for, therapeutic procedure in here. Locomat, even though they get a secondary cardiovascular effect, the reason we're doing Locomat is either for neuromuscular reeducation, but more primarily gait training. So we're billing the gait training code,
Gotcha.
both for inpatient and outpatient. Good question.
Is there an advantage to being able to bill across 3 codes compared to maybe only having 1 code available to you? Or
Great question. Yeah, they might. It's that's how you do your billing.
Yeah, right.
So we do what's called modalities. One modality is about a 15-minute interval of therapy. And because we're doing it for an hour and only about 15 minutes is that setup time, we've been able to, because we've incorporated sit-to-stand transfers in that process, we may even bill, and I just came to this, therapeutic activity to practice even standing and making them weight bear and balance while we bring in the Locomat, for example, or even here.
Yeah.
So you can get good at incorporating other purposes of the therapy into the real reason you're here, so you can bill
Right.
So, for example,
for the whole time versus
Yeah.
only half the
Right.
time.
And that's the question.
And
you
we have
asked.
we have never had denials that I'm aware of on either of these devices.
Okay.
and that's
no.
the big thing is, I mean, as far as salespeople and whatnot, a big
Uh-huh.
question always is, and like what you had mentioned is cost efficiency. And
Yes.
with that is, can there be a big return on your investment as far as a hospital system, a rehab facility, whatever that is? Is there good reimbursement?
You're bringing up
for
a
it?
good
You
point.
know what I mean? So, yeah, if you can touch on that or whatever
Sure.
things that you've seen with that.
When it comes to cost effectiveness, one, this is a much cheaper device, which
Yep.
is a great
Yep.
advantage of it and does nearly all the similar things. 2, it takes less clinicians. So this has come up amongst our leadership before. When you're doing manual body weight support treadmill training, you have upwards of 3 therapists, plus often an aide controlling the software, putting in all of our data and increasing speed and manning the treadmill. And then with Locomat, we have at least 2 clinicians at each time until we feel confident with the setup. We might drop down to 1. But with eye care, we can easily use just 1 clinician. So as management has stated, you have to think about the salaries we're billing for that hour 3 times a week. And that's where your costs really add up. So in terms of being more efficient as an organization, we too have also looked at this locomotor progression idea, because we can't all just be using the Locomat all the time, 2 or 3 of us at a time.
Yeah.
That's an expensive use for gait training. We need to be more cost effective across the board and try to go down to as few therapists required as possible. And think about using an aide, because obviously their salary is less and they help us. We have trained certain aides to help on each device. They're very knowledgeable and can help with setup and takedown, and then even running the software under our direction, of course, while we're focused more on the patient. So we've thought about all those ways, and we've actually went to other facilities. I've been to RIC, I've been to Shepherd in Atlanta, I've talked to the folks at Craig to see if we're delivering care as effectively as some of the other premier rehab hospitals are across the nation, and we're pretty consistent with how they do it.
Yeah, okay.
So, good question.
Yeah.
Is the setup time considered downtime that's not billable, or is it included as part of a certain?
If you can, again, incorporate, oh, we're going to work on your transfer, and you're going to stand here now while we quick hook up the harness in relation now to the Locomat, we can kind of bill for it. And otherwise, I know another bill we have that we do use, and I'm just thinking of this, is tests and measures. That billing code we use for our initial setup on almost any of the devices, except maybe the eye care.
You can only use that once.
We only use that once, yeah. That initial session, because for the Locomat, you've got to measure cuff size, leg length. Then you have to attach the cuffs to the machine. Then you got to incorporate their information into the software. It's time consuming only on the first session. And so we do a tests and measures charge, sometimes for 30 minutes if it takes us that long, or 1 unit for 15 minutes. And then the rest of the time we do gait training for that first session.
Because your setup on the eye care is so quick, you're
We can jump right into
building
treatment,
your
yeah.
2 minutes of setup.
No.
15-minute treatment or something like that.
Just like when you think about we can't build transport time to and from the patient's room, we try to be on time, knowing that if we can get 23 to 25 minutes in of a 30-minute session, our managers remind us, that's still 2 units of therapy. That's what they expect when they do QAs on the therapist's billable minutes per week.
Right.
They look to be sure we're not losing minutes from taking too long to bring them down to the gym or setup time, or we look at that on a routine basis to make sure we're being efficient. Because no, we should not be billing that. We have to be actively engaged.
Where it's a much greater setup time and more people.
We would do 4 units that we spent with the patient, but we may only bill for 3. That's what we handle. That's how we handle it on the subsequent sessions.
Yeah.
You only bill for the actual therapy you deliver. But you can get credit for being with the patient in the modality. It's just called, we call it non-billable. Yeah. No charge, sorry, that's the term it's used, no charge.
Isn't there, in the new codes, don't they have the code where you're doing multiple patients or residents?
Oh, concurrent therapy?
But can't you use that if you're setting up people prior to that? So let's say if you know you have 2 or 3 people coming in, especially with the local, can you be doing that and coding that? I've seen people.
Oh,
do
well,
that.
since we're only do 1 patient at a time, though, on these devices, we wouldn't be, maybe
Well,
I'm not
let's-
understanding your question.
Let's say I'm trying to efficiently use your day more with
Oh,
more patients.
uh-huh.
Does each device have a couple of devices that you can use? Are they different sizes, or do you manipulate that single set on the locomotive?
We manipulate it
So
by,
you only
for
have
each-
one
we only
set.
have
I
1
got it.
set.
Then
And
question.
once their information's in the computer, we use our technicians to have it ready to roll.
Gotcha.
That's already set up. Our setup time is built into their time as techs. So when we roll in the wheelchair from the unit, we're getting right in the Locomat,
Gotcha.
except for the first day when we got to do all the measurements.
Gotcha.
Good question.
One thing I would like, when we get to the end and everybody's gonna ask some questions, as an experienced therapist yourself and familiar, is could we do like, even just myself as a therapist, me using it for the first time, go through an entire setup?
You are being a
explanation?
leader again, because we have case studies coming up next.
Perfect.
You
Well-
better do that.
Perfect.
I don't mean to say I have, but I do actually have to go to an
Oh,
appointment, so
that's
it probably
all right,
can't be
that's
me, but I could find you a therapist.
No, this guy is always ahead.
You're
He's
good.
always-
He has great questions.
I want to ask you one more
Yeah.
question, and it just, I remember you recently published a study with colleagues from the Med Center talking about rural healthcare needs, physical therapy.
Yes.
Right now, we're talking about larger rehab hospitals, but can you speak to anything that you learned from that study where you were looking at rural healthcare needs that's relevant to the eye care? And if there's nothing that's relevant, that's useful? Are there limited technology, limited access technology?
It was more
Or
about
after?
access and what's available. And our study was done through UNMC, and I'm on the Nebraska Stroke Advisory Council. And a few years ago, we did essentially a needs assessment to see what clinicians in the rural areas. We looked at all 6, I'm not one of the researchers, there's a name for this. There's 6 regions of the state, and those include so many counties. So for instance, we're in the southeastern part of the state. We were more interested in the north, west, western, and central, where we knew that access to not only therapies, but especially technology was very limited. So we surveyed each of what we call critical access hospitals. Those are hospitals that have less than like 30 or 40 beds. They're very small, but are treating acutely affected stroke patients and deciding whether or not they can treat them there with TPA or ship them out to the closest stroke center. So besides looking at that, we also looked at what rehab services were provided in those smaller towns, both from a hospital-based rehab unit to a skilled nursing facility. And we found that clinicians just honestly did not have an idea on where, let's say, the nearest eye care is, or Locomat, or the nearest vision therapy was available, or driver's evaluation. So we took some key things. Partial body weight support was on there, which included eye care. Sorry, Dr. Burnfield. That one will make the list soon. Locomat was not on there. It was mainly partial body weight support, vision, driver's eval, stroke support group, things that we knew as a big rehab facility we had the luxury of having, but in small rural central Nebraska, their nearest stroke support group might be 3 hours away. And so the idea was we created then a database on the Nebraska Stroke Advisory Council website. Now, after we interviewed all those facilities and collected all the information, there's now a specialized service listing that all clinicians across the state can access that lists all those specialized services and where they're found, contact information, address, phone number, how to make a referral so that that patient could utilize that service, as well as the other part of our study looked at what percentage of time were staff in those rural hospitals and skilled nursing facilities utilizing stroke standardized assessments. Well, we know it was pretty minimal. You know, we are lucky to have built into our EMR, we do use the Berg balance. We do use, all the standardized assessments that are evidence-based for stroke rehab. We incorporate here in a bigger rehab type setting. But when you're out in a smaller setting, those therapists may not be as educated on all of those. So we did a lot of education then as well on standardized assessments and listed those on that website for them to access with a link to those so they could be utilizing those in their clinical practice. So it was more about standardized assessments and a team-based approach linked to where is access to certain specialized rehab services across this state.
Real quick follow-up, because I know you're going to go, but so was it also something like in those rural areas, nothing, and the therapists, do they also just not know about other types of treatment?
They did not, yeah.
And so this type of thing is just not marketed, or they just don't know it because they're outside of that realm of education?
It was very evident they had not been maybe exposed to it or was not aware that those were some of the options available for their patients.
And then also like in now those type of things, especially with smaller beds, treatments, in cardiopulmonary treatment, do you see something like this where it's transitory into full cardiopulmonary?
Yeah, I mean, I think a lot of our strokes, I can say, our stroke patients have obvious comorbid cardiovascular, cardiopulmonary conditions that I feel a device like the iCare only assists with improving their cardiovascular functioning. So I do see a real relevance it'd be very relevant to that patient population.
And I would think in that rural setting, I guess one of the other concerns would be to introduce partial body weight support treadmill training when you have just a small PT staff office.
Exactly.
In those facilities. If you lose one clinician, you may have lost
That's right.
half of your staff.
Yeah.
And so do you even have who can both take time from their day to deliver partial body weight support treadmill training? So that's a situation where
Something like this is more applicable to that size of setting, what they can afford, what space they have. And so now hopefully in our follow-up discussions with a lot of these facilities, we will be bringing up options like the eye care. You know, if they're inquiring about how they can get some of these affordable technologies in their rural settings.
Yeah. Awesome. Very good job.
Great, thank you.
Thank you, Amy.
Thanks. I'm happy to be here. Thank you.